Okay, so we have a few minutes for questions for Mark. So, Frank, I think I saw you first.
Very nice talk, Mark. Thank you so much. One thing that struck me, just looking at a lot of the slides, is how people in these studies, when you give the overview, they'd come in at their highest level of pain, and then over time they'd improve. And it didn't seem to matter that much, in terms of magnitude, between the treatment and the control group. And it just makes me wonder, is this regression to the mean? Do people come in when they're really having a tough time, and over time they just tend to do better? And it raises another interesting issue for me. I doubt that people are not doing anything, during that time in the two groups. They're probably doing other things. And whether there are processes when people have high levels of this type of pain, even if they don't come in for care, does it activate certain processes that people start to deal with it differently, or there's some biology that kicks in that maybe for the vast majority of people, they're going to show some improvements with time? And the third issue it raises is kind of comes to your final slide, is stop. It's basically do no harm. So when people come in with those very high levels, be really careful, we've heard about that today, about what you do, because there may actually be some natural processes that don't involve interacting with a healthcare provider that may be kicked in at those times that might help them over time. So I'd just be interested in your take on that general pattern that we see in these studies you reported.
And so, we've identified that also, and there definitely is. Right now in our clinic, we have some clinicians retiring, and so we're booked out more than we've ever been. And what's been happening is that people don't show, 3 months later, and we call them up and they say, well, I got better. But I don't want to diminish the people that have persistent pain and that have really severe pain, and they of course, this is an average. But one of my colleagues and friends is Mark Sullivan. He's written a book about the agency for the patient ability to make change in their health, and I think we if I've learned anything over the last 25, 30 years, it's that clinicians, we differ in our training, in our ability to connect with patients and be able to empower them. And it's something that all of healthcare providers need to learn. And it's not easy. It takes skill and training, but it's so critical for all aspects of healthcare. And I think with pain conditions and universal management of pain, it's just the first thing. What we train our students and residents are that the first thing you do with somebody that has pain is that you describe to them, what the condition is and what the diagnoses are in their lay language, so they really clearly understand. And then you reassure them. And then you tell them that there's therapy, that you're there to care about them, and you're going to never give up. And you give them this message, and it just makes a huge difference. And then when I first started talking about this 5 or 10 years ago, people said, Drangsholt, everybody knows that. I was like, I know, but they don't do it. Not everybody does that. And then when I talk with patients about what really made a difference, was it, was it Botox, or was it, this and, all these, and they said, no, Dr. Drangsholt, it was hearing from you, your explanation about the condition, and that, there was real hope that it was going to get better, et cetera. And one of the real quick thing is that when I was flying here, I was thinking over the last year about the patients that really had complex chronic pain in their orofacial region that are now dramatically better. Is the people that came in and I really thought that I didn't know if I was going to be able to help them. And I have, there's real hope, because I have people, and so other clinicians do too, but it was, it's a team approach usually. It's been a team of people. We work really hard, get the people really involved, and I've had people that are just dramatically better. And, we're pain intensity, we can only move down so far in some people with chronic continuous pain, but their pain impact then, I've got some people that they're 0 to 1 now. And they, I got my life back. And it's a comprehensive, multimodal approach. And so I feel more now than ever, more hopeful. And I feel like we have a lot of the tools, but there just isn't enough, there are not enough providers. There's not enough knowledge that's been spread out. It's just really, just not enough people.
Kathleen?
Thank you. So I liked your ending, stop, and let's rethink what we really need to do. I think you're right. There's just a wealth of clinical trials coming out in very low end numbers, not many subjects. But we've heard over and over that these interventions aimed at changing biomechanics, changing the system from that particular thing are not working, and maybe we need to rethink them. We also have heard that there's multiple underlying mechanisms in these guys, yet we put them in clinical trials as a single entity, and they all get the same treatment. Do you think that there's a place where we could start thinking about how you individualize treatment when they come to you? You look at people who might have more central sensitivity and give them more centrally driven treatments versus peripherally driven treatments and vice versa. Is there a way we could design trials that would actually capitalize on how you practice clinically? Because I don't think that's what our trials have been doing. And I'm just interested in your perspective on that. And then also thinking about predictors of success of treatments.
So I'm trying to think if I tried to anticipate some questions. That was actually one, and I don't know if I have some other slides about that. But we use some simple measures now from neurosensory testing to use just checking for mechanical allodynia in the trigeminal region. And by doing that, then we're able to then find people. You shouldn't have any pain with light touch. It's normal. It's abnormal. So we do that in everybody, or 99% of people. And so then we're able to detect people. So for example, I had a lady that was sent to me that had, she had widespread pain, but she also had TMD, and then she was sent to me for me to administer Botox for her TMD problem. Well, so we did full exam, and then I gave her a pain drawing, which is really helpful, saw her whole body pain, and then also showed that she had these neurosensory abnormalities. And so I said, well, have you ever tried pregabalin? No, I've never tried that. So we did trial pregabalin, low dose. She came back, and then her TMD is much better. Her whole body pain is much better. Because she basically had, TMD-associated, fibromyalgia. I mean, it's a completely different condition, completely different. And so got maybe a little lucky in that case, but it's a good example, I think, of being able to have very specific diagnoses. And then if you have those specific diagnoses, then you can have more specific therapy that's going to be more valuable. Because right now, it's really, it's just TMD. As a general category, when I look at it now, it's not even 31 flavors. It's like 145 different flavors of TMD because there's all these different. It's whether they have central sensitization and whether they have widespread pain and whether they have, besides all the other, they have sleep disturbance. We just had somebody else that came in. She had sleep disturbance, but it seemed like more like acute pain, but she had continuous pain. And we got her to sleep well with amitriptyline, and she came back and she had pain for 18 months. She was just dramatically better by just having that trial. So we do lots of trials, and so we start with baseline measures, talk to the patient, do a trial. It could multimodal, could be anything from self-care to medications to appliances, and then see how people do. And what I found is that with the precision medicine kind of paradigm, I cannot predict, though, nearly as well as I think I can. I just can't predict. So the only way forward then is, if we don't have the biomarkers, is to go and have a rational approach to say, well, this is what we think would be the best. Do this trial, redo all the measures, see how they're doing, talk with the patient, and then consider doing other trials. So most people, I can do trials and help them in 2 or 3 trials, but right now I have some patients that were at 50, 60 trials, and we're still going. We don't give up. And work with others. So I don't know if I quite answered that.
How do you put that process in?
We're about at time here, and we've got a bunch more folks to come on. So thanks very much, Mark.
Hey, you're welcome. Thank you.